All right. Okay, can you see the slides of the Word document?
Yes, Doc.
All right.
Yes,
Is my
Doc.
audio clear? Is my audio clear?
Clear man, Doc?
Sige. So before we go to our discussion, um, let me rationalize first your examination. All right. For number one, this is a very simple recall. Which of the following is an inhaled corticosteroid? What will be your answer? Chris, ini. Wrong. Dali lang. Tingnan ko dulain mo to question number one ko. Shucks, kalawya. Ako nulain man to itsura sa exam. All right. Hello?
Hello, sir.
Okay na? All right.
Fine, sir.
Let's rationalize the exam. So for question number one, no is a clinic nurse caring for patient with COPD. The patient asked the nurse what he could have done to minimize the risk. Okay, underline minimizing the risk of contracting this disease. Okay, what is the major risk factor for COPD? Anybody?
Cigarette smoke.
Smoking.
Very
Smoking.
good.
Smoking.
Smoking. So you have to emphasize to the patient the risk factor, which is smoking, that predispose COPD. For those who are non-smoker, what could be the factor leading to COPD?
Deficiency in
Alpha
antitrypsin
antitrypsin
Trypsin.
deficiency.
Okay, very good. Your deficiency in alpha 1 antitrypsin. All right. So that makes letter D the correct answer. Next, number two. The nurse creating a health promotion intervention focused on chronic obstructive pulmonary disease. What should the nurse identify as a complication of COPD? The end product of COPD is respiratory failure. What particular respiratory failure? Type 1, type 2, type 3? Anybody? Remember what happened, no? Go back to your go back to your pathophysiology and COPD. What happened? There is air trapping, there is carbon dioxide trapping. So what type of respiratory failure will you expect? Type 1, type 2, type 3.
Type 2, Doc.
Type Doc.
You're good. Okay, type 2 respiratory failure. Correct. All right. A nurse is caring for a young adult patient whose medical history includes alpha 1 antitrypsin deficiency. So therefore, you are entertaining what? You are entertaining chronic obstructive pulmonary disease. Now, this deficiency will predispose to what? Okay, wala si OPD. Diba? COPD has two types. It can be either pulmonary emphysema or what's the other one?
Chronic bronchitis.
Chronic bronchitis.
Chronic bronchitis. So anong are sa choices that leads to COPD? Ano? Hello?
Organ Doc.
Oh, ano ang are sa choices that leads to COPD?
Lobular, no?
Emphysema.
Okay, very
Letter
good.
B.
Emphysema. Emphysema. Kasi nga, what did they tell you? Alpha 1 antitrypsin deficiency to this patient develop COPD. You have chronic bronchitis. So, anong are sa choices? Your pulmonary emphysema. All right. Next. The nurse is assessing a patient whose respiratory disease is characterized by is characterized by chronic hyperinflation of the lungs. What should be the most likely diagnosis for this patient, or what most likely you will assess? The presence of a barrel chest. This is a compensatory mechanism of hyperinflation. Number 5. A patient with emphysema is experiencing shortness of breath. To relieve the patient's symptoms, what will you do? You assist the patient in a sitting upright position with leaning forward slightly. This is what we call your tripod position. This is to facilitate expectoration of air. Next. A school nurse is caring for a 10-year-old who is having an asthma attack. What is the preferred intervention to elevate this client? Now, what we are asking here, is it a controller or a reliever?
Reliever.
Anybody? Very good. Reliever. So, pag reliever, ano ihatag nyo?
Saba.
Okay, a short-acting beta-2 agonist. Correct. Now, a student nurse is developing a teaching plan for an adult patient with asthma. Which teaching point should have the highest priority? Remember, asthma has its exacerbation. So to prevent exacerbation of asthma, you advise the student nurse to take the medication as scheduled. And that is your controller. What is the controller of choice? Your inhaled corticosteroids. Okay. Basta any inhaled corticosteroid. All right. A student nurse is preparing to care for a patient with bronchiectasis. So what is bronchiectasis? This is simply your dilation
of the lungs.
and bronchioles, causing Rasmussen aneurysm, causing hemoptysis.
Collapse of the lungs.
All right. Now, a nurse is completing a focused respiratory assessment for a child with asthma. Which assessment finding is most closely associated with the characteristic sign of asthma? Of course, bilateral wheezes. That's very simple because of airflow limitation and hyper-responsiveness. A nurse is developing a teaching portion of a care plan for a patient with COPD. What would be the most important component for the nurse to emphasize. Remember, COPD, this is exposure to smoke, and chronic inhalation of indoor toxins can cause your lung damage. All right. Do we allow smoking? Di ba wala? Minor respiratory infection are considered to be self-limited and are not treated. Actually, we have to treat this because it will predispose sputum production. And your activity of daily living should not be clustered, okay? It should be routinely done. All right. A patient is having a pulmonary function studies performed and the spirometry test is 60%. What will be your parameter gani? Di ba 80? Pag less than 70, may ano? Ano ang sakit if this is less than 70?
Obstructive.
Obstructive.
Obstruct.
Okay, any obstructive lung disease, may it COPD, may it bronchial asthma. Pag normal,
75 to
objective
80.
pa ba? Pag normal, obstructive disease pa ba? Ano siya? Restrictive lung disease. So this is last case of obstructive work up already understand because smoking is
Excuse me, Doc. Sabi ka, Doc.
Kamusta ka mo guys?
Okay lang kami, Ed. Okay lang, Ed.
Oh, hello? Is my audio clear? Sorry ha, phone lang ni gamit ko ha. Ga-data lang ako.
Clear man, Doc?
This is data lang, gid. Paano di mag-call man? Share caption. Share screen ba? Stop broadcast. Paano mag-share man? Actually, wait lang. Share screen. Papers. Mute. Everything on your screen, including notification, will be recorded. Huh? Screen broadcast ba? Is this the same lang? Is this the same kung gagamit ng ko phone to laptop? Hindi ko ma-show. Show caption and others. Settings. Oh, how can I share screen using phone? Dulain na niya how. So this will be recorded ayun? Hello? Ano i-click ko? Share screen. Get. Screen. Start broadcast. So this will be recorded. Can you see my screen?
Yes, Doc.
Okay. So, amo na siya gali. Alright. Sorry, medyo na-alter ang format ha because this is a phone already. Hindi ko mapadayon ang hindi ko mapadayon ang rationalization. I'll go with the formal topic right now because of the limited number of time. I'm using data and I'm using my battery. Tapos akong battery parang mag-run out of life. Alright. So we begin, no? A normal sinus rhythm, this is the usual rhythm that begins where? In your primary pacemaker, which is the SA node, which is located in the junction. Hello? Hello? What is
We
it?
can hear you, Doc.
Ha? Ano? Choppy? Hello? Choppy ba ako?
Batian ka, Doc.
Ha? Medyo choppy ako. Choppy ba ako?
Batian ka man, Doc?
Wait lang, gano'n. I'm going to use na lang my headphone. Hold for a while. Hello? Okay na? Am I clear? Am I clear?
Yes, Doc. Yes,
All
Doc.
right. Sige. Sorry, I cannot use my laptop at the moment. Maybe it's my laptop where there is incompatibility problem with the connection. So there is a change now in the format because I'm using my phone. Let's continue with our discussion instead of rationalization. We'll go back with the rationalization next week once I have a stable connection already. All right. Now just remember that the normal sinus rhythm is between 60 to 100 beats per minute, and this is originated in the SA node. Remember that the SA node is located in the junction of the right atrium and the superior vena cava. Now, in the event that the SA node malfunction, what will be your backup pacemaker? Anybody?
AV node, Doc.
Okay,
AV.
AV node or your atrioventricular node with a firing rate of 40 to 60, correct. And as a normal interval with no apparent ectopic beats. Now, remember guys, if there is dysrhythmia, the problem is in the rhythm of the heart. Again, I repeat, if there is dysrhythmia, this means problem or disorder or difficulty. So therefore, there is problem in the rhythm of the heart. Now, paano ko ni ma-change? All right. This is page 1 and this is page 2. All right. Now, it is the disturbance in the cardiac, in the electrical cycle of the heart. Remember, from the SA node to the AV node to the Purkinje fiber, to the bundle of His, then to the Purkinje fibers. And the Purkinje fibers help to contract the myocardium. So if there is a problem here in your electrical cycle, then it will lead to your dysrhythmia. All right, what are the major risk factors to develop dysrhythmia? Number one, remember the three major mechanisms why the heart beats. That is because of automaticity, meaning your heart will just beat because of the electrical impulses. No matter what happened, you cannot control the beat of your heart. The second one is the conduction. Conduction is by the electrical impulse from the SA node to AV node to bundle of His to the Purkinje fibers. And this conduction enables our heart to beat. And lastly is the re-entry of impulses. Remember that these impulses are being recycled from one cycle to another. Now, what will be the disturbance in automaticity? Number one, if there is myocardial ischemia. If the heart is depleted with oxygen and there is damage in a portion of it, then it will lead to decrease in automaticity. Number two is decreased left ventricular function. Remember that the left ventricle is a powerful contractile chamber of the heart. If there is decrease in the contraction of the left ventricle, then the cardiac output will decrease and the electrical impulse will also decrease. Next, you have your valvular heart disease. This is if your cardiac valves are involved. So what are your valves, gani? Two main category of valves. What are these?
Tricuspid valve.
I'm asking for the two main category. What are the two main categories of your valves? Buddy, what are the two main categories of your valves? Alba. Miss Diaz. Diba? You have your atrioventricular valve and the semilunar valve. What are the examples of your atrioventricular valve? Hello? Am I clear? What are the examples of your atrioventricular valve? Diin nyo na. Brown out na ako karam.
Tricuspid and bicuspid.
Correct. Okay, tricuspid and your bicuspid valve or your mitral valve. What about your semilunar valves? Guys, this is just a basic anatomy. You should have mastered this already.
Pulmonic valve.
Pulmonic and aortic valve.
Gargutan it will not allow the backflow of the blood. If it is a stenotic valve, then its diameter or caliber is decreased. So therefore, there is less area, no, to be pumped out. That's the reason why there is too much exertion leading to loss of automaticity. Then you have your electrolyte imbalance. What particular electrolyte is responsible for cardiac conduction? What are three electrolytes?
Potassium.
Okay, correct. What
Calcium.
else? What
Magnesium.
else? Calcium, ano pa?
Sodium.
One more.
Sodium.
Okay, sodium.
Sodium.
Sodium is responsible for your fast sodium channel that starts the depolarization. Then calcium is responsible for the plateau of your action potential. And lastly is potassium, which is responsible for repolarization or resting state, as well as spastic contraction. Then you have your hypoxia. Hypoxia is decreased oxygen level in the tissues. Thereby, it can lead to myocardial ischemia and lead to decrease in automaticity. Then, of course, your digitalis toxicity. Okay, question. What is the action of your digitalis? Example then of your digitalis or your cardiac glycoside.
Digoxin.
Digoxin. Okay, what is the action of your digoxin? Correct. What is
Decrease
the action?
cardiac contractility, doc.
Sorry?
Decrease cardiac contractility.
Siguraduha.
Increase cardiac contractility.
Okay, be careful, ha? It increases the cardiac muscle contractility, but it decreases what?
Heart rate, Doc.
Correct. Okay, tandaan, ha? Hindi nyo pagbalik tara, Diyos ko, Lord. Oo. It increases the cardiac myocardial contractility, not decrease, and it decreases the heart rate. So increasing myocardial contractility, decreasing the heart rate. Then you have the administration of your atropine. Okay, what is atropine? Anybody? What is atropine?
Increase
What's the
secretion.
wrong? Oh, pwede. Partly correct. What else? What's the category of your atropine? This is a sympathomimetic anticholinergic. So it decreases the secretion at the same time. Tanong niya sympa effect. All right. Same with your disturbance in cardiac conduction. It also involves your myocardial ischemia, valvular heart disease, inflammation of the AV node. Remember that the AV node is the relaying center of your SA node. So this is your backup pacemaker. If any problem with your AV node, it can lead to AV block causing an ectopic beat. Then electrolyte imbalance, digitalis toxicity. Okay, beta blocker. How does beta blocker decreases the conduction? Particularly what? Beta 1, beta 2?
1, Doc.
Correct. Beta 1. What is the action of your beta 1?
Vasoconstriction.
Siguraduha.
It
Hindi ka
inhibits
muna.
the action, Doc, of adrenaline and noradrenaline sa heart, Doc.
Ang blocking. Pero ang function niya sa beta 1, Danay. Physiologically, what is the function of your beta 1? Let me see. Okay, ako matukso, ha? Benedict, what is the action of your beta 1? Benedict, what's the action of your beta 1? Elmer. Elmer, what's the action of your beta 1? Hello? Do I have students here? Compound. Jet. Jet Angelo. What's the action of your beta 1? Are you around? Are you around, guys? Madalian na. Gulat ako. Ano sa bar?
Uh, yes, it blocks the effects of the norepinephrine and the epinephrine, doc. Thus,
If it's
uh,
blocker, I'm asking for
it
the physiologic function.
facilitates the sympathetic effect, thus increasing the heart rate of
Correct.
the individual.
Correct. So it mediates your sympathetic effect, causing the elevation of your cardiac contractility, leading to increase in heart rate. Next time when I ask, please answer, even if you don't know, for me to know whether you are around or not. For those who cannot answer or cannot make any comment, automatic absent, ha? All right, let's continue. Okay, so we have also myocardial infarction, especially inferior wall. Now, what part on your ECG are you going to look for the inferior wall? Okay, what particular part of ECG?
VF, doc.
What else? What else? Let me see. Ako na namang tukso, ha?
3.
Ako pa magtukso. Wait lang. Mr. Tablo, what particular part of ECG are you going to look for?
Sa cancer, sa AVF,
Ano pa?
sa limb 2 and limb 3, sir.
Okay, very good. 2, 3, and AVF.
Yes, sir.
Correct, very good. All right, so your re-entry process, you have, like, for example, myocardial ischemia, the action of your antiarrhythmic medications, myocardial fibrosis, and bundle branch block, which we will be discussing later on. All right. So let's go with the pathophysiology of your cardiac dysrhythmia. Remember that any dysrhythmia has problem on the cardiac output and therefore leads to cerebral or vascular perfusion problem. Now, just remember that the cardiac output is stroke volume times the heart rate. Okay? So during a normal sinus rhythm, the atria contract to fill and stretch the ventricle with about 30% more of the blood. Then there is what we call your atrial kick that increases the amount of the stroke volume before the ventricle contracts. And when the ventricle contracts, it increases your cardiac output by about 30%. This is the time that the impulses originate from the SA node to the AV node and fire to the bundle branches and to the Purkinje fibers. So if there is loss of the atrial kick, then there is problem in your cardiac output by 30%. So how do we know that there is arrhythmia? Because you cannot really have symptoms of arrhythmia unless you develop palpitations. Ano pa? There is dizziness. The reason for the dizziness is that the brain is less perfused. Remember in the previous pathophysiology, there is problem in your cardiac conduction, so therefore there is problem in the contractility, leading to decrease in the vascular and cerebral perfusion. Same as true with this. Now, a reduce in cardiac output could lead to palpitation and dizziness. Then you have pre-syncope or about to decrease, no? Pre-syncope, pallor, diaphoresis, and altered ventilation. All right, you will also have your shortness of breath, orthopnea, paroxysmal nocturnal dyspnea, or the presence of difficulty of breathing at night, hypotension or decrease in blood pressure, sluggish capillary refill because of the decrease in perfusion, swelling of the extremities, and decrease in cardiac output. Now, what will be your diagnostic assessment? So for history, you would ask for the onset, duration, associated with the clinical manifestations, the aggravating factors, and the relieving factors. For the past medical history, you should note for the presence of cardiovascular diseases and factor analysis, past health history and hospitalization, and of course, presence of surgery, allergic to medication and food, dietary habits, alcohol and tobacco, and the family history. Now, for physical examination, you will be able to auscultate for any abnormal heart sound, slow or fast rate, there is irregularity or the presence of murmur, the ACG, your Holter monitor, which is a continuous record of your cardiac rhythm for 24 hours. And for your event monitor, no, for the client who did not experience dysrhythmia within 24 hours or a period of recording, you will have event monitor as available. An example for this is an example for this is your Holter monitoring. So you have also your invasive electrophysiologic studies, which involves the positioning of a multipolar catheter electrodes into the venous system, placing the electrodes at the various sites along the atria, ventricle, bundle of His, and other accessory pathways. All right, so let's discuss the different types of dysrhythmia. Now, remember that it depends on the structures involved for your dysrhythmia. So if the problem is in the SA node or in the primary pacemaker, you will have your sinus bradycardia or decrease in heart rate than the normal, sinus tachycardia, or this is the increase in heart rate from normal, and the sinus arrest or what we call your sinus pause. Another is if the rhythm no starts from atrial, you have your atrial flutter, atrial paroxysmal supraventricular tachycardia, premature contraction phase. Now, if the problem naman is in the AVD junction, then you will have your premature junctional complex, junctional escape rhythm, and junctional tachycardia. If the problem is in the ventricles, then you will have your premature ventricular contraction, your ventricular fibrillation or your VFib, and ventricular tachycardia. All right, let's discuss them one by one. So we have the rhythms originating in the SA node. Number one is your sinus tract tachycardia. Of course, this is a regular rhythm. However, this is decreased from the normal value, which is 60. So anything less than 60 with a regular rhythm, that's sinus bradycardia. What will cause sinus bradycardia? Number one is decreased activity. For example, you are sleeping, you are well rested, then a chance of having a sinus bradycardia is likely. Another is if you are taking digoxin. Diba? Digoxin has its function to increase your cardiac muscle contractility, but they can decrease the heart rate, which can lead to sinus bradycardia. Now, what will be your treatment for sinus bradycardia? Since this is a parasympathetic effect, you give sympathetic or anticholinergic in the form of atropine. What is the dose? 0.5 milligrams IV. But don't worry, I will not give this in your exam, the dose. No, it is suffice you to know that in presence of sinus bradycardia, you prepare for an atropine. But in the persistence of a sinus bradycardia, you will have also your pacemaker. Now, in what scenario will you expect also sinus bradycardia as a normal finding? San o?
Athlete.
Sorry?
Athlete.
Go ahead. Very good. Sino na? Hindi ko makita. Sino sa ba?
Rest.
Okay, why? Why will you observe bradycardia in athlete? That's correct.
Kay permi sila exercise Doc. So, ila heart sanay na sa mga
Sige pa. Amo na ang umpisa. Anong sugpon dayon? What will happen to the heart? What will happen to the heart? Because of
So,
frequent exercise.
ang heart kumbaga, gina-recognize niya sa normal ang pagiging brady natin.
No. At sakto na to, tani. Because of so much exercise, remember, heart is a muscle. It could lead to cardiac muscle hypertrophy. It thickens the cardiac muscle, thereby it can decrease the contractility. Okay? So this is your sinus bradycardia. Okay, determine the rate. What is the rate for this patient? Remember, this is a regular rhythm. What is the rate? You can use 300, you can use 1,500. Or Jet Angelo. Determine the rate.
Wait lang, Doc.
Pila. As I said, you can use 1,500 or you can use
37.5 Doc.
sige na, Jet pila. Then you can use 100 or you can use the 300 method.
Doc, 38, Doc.
Okay. So if you are using 300 by because of it, large boxes in between 1,500 1,500 divided by 40. All right. They have sinus tachycardia. It is a heart rhythm that is initiated in the SI node. Regular rhythm is in 100. So the example to correct the cause. But in certain situations, no, you can use a beta blocker to decrease the cardiac. So this is sinus tachycardia. And you calculate. Pila. Arthur. What is the rate? Arthur.
Doc.
Pila ang rate? Okay. You can use 1,000. Or you can you cannot use 300. Pwede. May isa di ka na rhythm. Oo nga, pwede ka gamit 300. Pila?
150, Doc.
Correct. Okay, 150. Then you have your sinus arrest, no? Wherein your sinus node automaticity is decreased and the impulse is not formed when expected. So kumbaga, the result is the absence of your wave. Remember, P wave is because of atrial contraction. So there might be absence in your P wave. All right. Result in the P wave, the QRS complex, and there is no electrical activity for approximately 3 seconds. So what will be your treatment? Of course, you can give atropine, which may increase your cardiac rate. Pag hindi kaya, you can give pacemaker. Like this one. Okay. Okay na. So we go to the rhythms originating in the atria. Number one, we have the atrial flutter. This is a single ectopic focus firing rate of about 250 to 350 beats per minute, resulting in the ventricular response that is lower but with multiple atrial rates. Tandaan, ang rate diri is not the ventricular but the atrial rate. Wait lang. Wait lang ha. Usually, P wave are replaced by flatter waves that become sawtooth appearance. So this is your sawtooth appearance. So there are multiple P waves. So what will you give? Calcium channel blocker. You can give also beta blocker, and we can do cardioversion initially at 50 joules. All right, let's talk about atrial fibrillation. Now, in your atrial fibrillation, this is an abnormal rhythm originating from multiple ectopic focus in the atrium. Again, I'll repeat, there is a multiple ectopic focus in the atrium. So it is disorganized twitching of the atria at the rate of more than 350 beats per minute. So there is multiple focus. So this is your atrial fibrillation. The atria is not contracting well. No, there is tetanic contraction in the atria. Wait lang. So what will be your treatment? You can give your calcium channel blocker in the form of diltiazem. Remember, no, hindi ko di ka-annotate. Please take note lang of your dihydropyridine and non-dihydropyridine. For your dihydropyridine calcium channel blocker, these are your calcium channel blocker that acts as antihypertensive. I'll repeat, dihydropyridine. This is your antihypertensive calcium channel blocker. For the non-dihydropyridine, these are your antiarrhythmic. Okay? So you can have also your beta blockers in the form of metoprolol, digoxin, amiodarone, and cardioversion. Then we'll have also paroxysmal supraventricular tachycardia. This is a dysrhythmia originating in an ectopic focus anywhere above the bifurcation of the bundle of His. So anything above it, this is supravita. Here. Tandaan nyo yung mga pictures ha. I-send ko man yung copy sa inyo, don't worry. Treatment, we can give beta blocker. Okay, sorry, good for a while. Oh my God. Wait lang good, guys. So we can give here beta blockers. Now let's go to the rhythms originating in the atrioventricular junctions. So first we have your premature junctional rhythm or your premature junctional complex. Ay, isa naman iniman. Sorry. Hold on please. Hold on lang, wait lang. All right. So for your premature junctional complex, this is basically an ectopic the AV junction outside the normal cardiac cycle. And this will just resolve. This is your PAC or your premature, sorry, PVC or your premature ventricular contraction. The AFib gan ginutang ba. Then you will also have your junctional escape. The junctional escape occurs when the atrial rate is low, usually less than 30 beats per minute, and the atrioventricular node assumes the responsibility um, of the cardiac pacemaker. So therefore, the cardiac rate is less than 60. Wait lang yun. All right. So this is your junctional escape. Wait lang din. All right. Sorry ha, I talk so fast. Okay, ako nga battery, dali na lang good. So we have your junctional tachycardia. It occurs when the AV node becomes irritable and overrides with your sinus impulses. That becomes the primary pacemaker at a rate of greater than 60 beats per minute. This time. In blockers, blockers are dehydrated. You can have oxygen, but never like those rhythms originating in the ventricle. We have your PVCs of your premature ventricular conjunction. This is a desired-looking QRS complex, desire-looking QRS complex, which is an ectopic beat originating from a site in the ventricles outside of the normal cardiac cycle here. Na tandaan nyo, amo mo lang siya, Bigemini, PVC and Bigemini. First, look at that. Normal PVC, normal PVC. So you just count 1, 2, 1, 2, 1, 2. Nakuha nyo? Normal rhythm, then a PVC. Normal rhythm, then a PVC. That's a bigeminy. Premature ventricular contraction in bigeminy. In trigeminy, it's every 3. Normal, normal PVC, normal, normal PVC. Okay? Parang 1, 2, 3, 1, 2, 3. Okay? Nakuha. Diba? Pag bigeminy, 1, 2, 1, 2. Normal PVC, normal PVC. Diba? Ano hamba ko gani sa inyo? Ang PVC is a bizarre-looking QRS complex. So it's a normal PVC, normal PVC. Now, ano pa to gani ang kadua? Then you have also your PVC in trigeminy. So PVC in trigeminy, normal. 1, 2, 3. Nakuha. Nakuha,
Yes,
guys. Alright. What if duwa ka PVC sunod? Ano siya? PVC, PVC. Duwa siya kasunod niya PVC. Ano ang sabat? VTAC. Tandaan nyo na ha? VTAC. Okay. Clear? Clear, guys.
Yes, Doc.
Anong Vita, Doc?
VTAC, ventricular tachycardia. VTAC, ventricular tachycardia. All right. So what will be your treatment? You will have beta blocker, procainamide, which is a class 1 antiarrhythmic drug, amiodarone, which is class 3. And lidocaine, which is also class 1. Ang mga anti-arrhythmic drugs like Spinraza, pag ginahinga ako. Actually, also ako from time to time, pina-charge ko siya ang phone sa laptop. Then, have your ventricular fibrillation. This is a premature ventricular contraction that falls on T wave that may precipitate a ventricular fibrillation. Okay, pagtandaan fibrillation, alam no, in the pagbeat ng ventricle causing ano ganun siya? Titanic beat. This one. Then you have ventricular tachycardia. Of course, this occurs if there is a matahambak or disease. 3 or more nagkasunod is already. Now, for patients who are hemodynamically stable, we can give amiodarone. But if unstable, you can do diversion. Pag pulseless, then we go defibrillation. Cardioversion is i-revert mo lang ang rhythm. Defibrillation is i-stop mo ang tetanic contraction. Alright? Sige. Ay, salamat! Wala pa ako nalobat. Anyway, if you have any question for this, feel free next week. Alright? Thank you, everyone.
Sir, pwede sir mabalik sa last slide, sir. Kaya wala, dabi, nag-untat, sir.
Ang ano?
Ang sa last slide,
Ano
wala,
na?
sir, wala na mo nakuha. Kaya nag-slide bala ang PowerPoint.
Yeah? Don't worry. 12 slide. Isang subong.
Okay,
Isang
thank
ko
you.
ni subong.
Thank you, Doc.
Okay.
Bye,
Nalabot na ako.
Thank you, Doc.
Goodbye, Doc.
Bye.
Thank you, Doc.
Thank you, Doc.
Thank you, Doc.